Thank you very much, Mr. Chairman. Today I will discuss with you the antiphospholipid syndrome. And doing so, I think it's quite good to start with the history, or more or less say the prehistory of the antiphospholipid syndrome, before it was really described as antiphospholipid syndrome. The first publication that describes two patients which we think now should have the antiphospholipid syndrome was in 1952 by Conley and Hartman, and he described two patients with systemic lupus erythematosus, indicating that these patients had an autoimmune disease. They had a very peculiar hemorrhagic disorder. And what was so peculiar on this hemorrhagic disorder, that although they had extremely long coagulation times, they did not bleed. They also described that the prolongation of the clotting time could not be corrected by mixing with normal pooled plasma, and there was no inhibition of the thrombin time, so indicating that this what we now will call a lupus anticoagulant. Also, the inhibitor was stable at 65 degrees and unstable at 80 degrees, indicating that it has to do here with an antibody. And moreover, there was false positive syphilis test, and at that time syphilis was measured as antibodies against cardiolipin, so there was also indication that these patients had anti-cardiolipin antibodies. This was an observation, was not understood, but the first indication that this inhibitor in plasma had clinical consequence was from a French group who published a report on a patient with this peculiar anticoagulant and 7 previous abortions. And this was the first article showing that the presence of this peculiar inhibitor coincides with pregnancy morbidity. That was before the first publication on the relation of these antibodies and thrombosis. That was in 1957. There was the first publication by Laurel and Nielsen, who showed that the patient with this inhibitor had thrombotic complications, despite the fact that he has prolonged coagulation time. Moreover, he also described in this patient that he was, again, a positive test for syphilis, so this was in fact the first case report showing an association between the presence of this anticoagulant, thrombosis, and the presence of something against cardiolipin. A quite interesting paper was in 1959 from Dutch group, from Leuweger, who showed in fact that when this circulating anticoagulant was present, it was depending on a cofactor. So it indicates for the first time that there was a protein involved, and he describes prothrombin as the cofactor, but later on other cofactors has been described, and in fact prothrombin turns out not to be the most important one, but he was the first one showing that there was a cofactor, a protein involved in this inhibitor. A hallmark study was published in 1963 by Walter Bowie and Charles Owen, who described in a larger study, not so large, there were in fact 8 patients, but from these 8 patients who had the circulating anticoagulant, 4 of these had thrombosis. And it was the first hard indication that the presence of this inhibitor coincides with thrombotic complications. Feinstein then introduced a new word for this inhibitor. He called it the lupus anticoagulant, and he named lupus anticoagulant for an autoantibody present in patients with systemic lupus erythematosus that cause a prolongation of a clotting time without causing bleeding tendency, but seems to be correlated with a thrombotic tendency. Later on, this name turns out to be a misnomer, because this anticoagulant is not only present in patients with systemic lupus erythematosus, but it's also present in other patients. But it is very common in patients with systemic lupus erythematosus. As clotting assays are very difficult to perform in many laboratories, there were thoughts to introduce other assays, and Nigel Harris introduces ELISA to measure the same antibodies. He was clever, he knew that all these patients had also antibodies against cardiolipin, so he introduced an anti-cardiolipin ELISA because these patients had a positive syphilis test, and he introduced this ELISA to make it available for many more laboratories to measure this inhibitor than only laboratories that can do a coagulation assay. And based on these observations, his boss, Graham Hughes, was the first one who defined the syndrome, the antiphospholipid syndrome. He defined that in 1985, and it is a very simple definition. A patient with thrombosis, and when he has in his plasma a lupus anticoagulant activity and anti-cardiolipin antibodies, and he decided that you have these antibodies twice, so it should be persistently present, then you have, by definition, the antiphospholipid syndrome. The same is true for a patient with recurrent pregnancy losses and the presence of this persistently lupus anticoagulant or anti-cardiolipin antibodies. He has, or she has, by definition, the antiphospholipid syndrome. And the antiphospholipid antibody-related thrombotic complications you can find in almost every vessel of the body. Venous, arterial, in large vessels and small vessels, but in fact most common is deep venous thrombosis, And second place is strokes, but you can find indeed thrombosis in every part of your body. And the antiphospholipid antibody-related pregnancy problems are more than 3 consecutive unexplained losses before 10 weeks of gestation. And you can question whether this is a thrombotic complication or something else. 1 or more unexplained fetal deaths with normal morphology after 10 weeks of gestation, and 1 or more premature birth before 34 weeks of gestation because of severe preeclampsia or placental insufficiency. These latter ones can be due to thrombotic complications in the placenta, but it is questionable if all the pregnant problems are indeed due to thrombotic complications. Next to that, you very often see other clinical complications in these patients. They are not officially part of the clinical manifestation that defines the syndrome, but you very often see them. You see hematological problems like thrombocytopenia, prolonged bleeding time, hemolysis. You see problems in the skin, livedo uricularis. Cardiopulmonary problems, especially heart valve abnormalities, are very often seen. Neurological problems and also nephropathy. And all these symptoms are probably not all due to thrombotic complications. There should be something else that causes these problems. And it is that, and you do not see all these additional manifestations. You don't see them in all patients, but some patients, you don't see that with other hypercoagulable states. So I think that the antiphospholipid syndrome has a kind of unique pathophysiology because they have also all these other manifestations. One of the important things is that the antiphospholipid has a wrong name. After the definition, it was found out that the antiphospholipid antibodies that define the syndrome are not directed against phospholipids, but they are directed against proteins that bind to negatively charged phospholipids. And many different proteins has been described. I think there are more than 20 different proteins has been described to which antibodies are directed in this syndrome. But we now all agree that the antibodies against one protein, beta-glucoprotein 1, are generally accepted as the most relevant clinical antibodies. And here you see the crystal structure of beta-glucoprotein 1. You see that it is built up out of 5 different domains, especially domain 5 is interesting because you see here a space-filling model in which the positive charged amino acids are blue, and you can see that in domain 5 there's a huge patch of positive charge due to large number of lysines, and with this domain 5 it can bind very well to all kinds of negatively charged phospholipids, explaining why this protein binds very good to phospholipids and the antibodies then can bind to this protein. Because this protein is so important, and ELISAs were developed also to measure this protein, during a consensus meeting in Sydney a few years ago, it was decided to add a 3rd assay to the definition of the antiphospholipid syndrome. So now the definition is patient with thrombosis or recurrent pregnancy loss when it has in its plasma lupus anticoagulant, anticoagulant antibody, or anti-beta-glucoprotein 1 antibodies. By definition, this patient has the antiphospholipid syndrome. One important thing to realize is that the clinical manifestations that characterize this syndrome, such as pregnancy complications and thrombosis, are quite common in the general population, and in most cases not due to the presence of antiphospholipid antibodies. In fact, less than 1% of all the thrombotic complications are due to the presence of these antiphospholipid antibodies. So it is very difficult to define the syndrome only on clinical manifestations. In fact, to make the definition, you need a laboratory. The presence of antiphospholipid antibodies is mandatory to make the diagnosis. Thus, in fact, the antiphospholipid syndrome is a disease that is defined in the laboratory, and that makes some important conclusions. Because you can think of many things. You have 3 different assays, and the question is, when you have 3 different assays, are they doing as good as all 3 evenly good, or are there differences in between the 3 different assays? And it was clear from the beginning that if you have these 3 assays, that they are not the same. The antibodies that you will detect in the lupus anticoagulant, the antibodies that you detect with the anticoagulant ELISA or with the anti-beta-glucoprotein 1 ELISA are overlapping but not the same. Many patients have all 3 antibodies, some have 2, some have 1. So they are not identical. So you can ask yourself the question, which of these assays is the best one to detect the patients? And there has been a Medline search by Monica Galli a number of years ago. He combined all the studies, and the conclusion of these studies was very clear, that lupus anticoagulant was by far the strongest risk factor for every type of thrombosis. And in fact, anticoagulant antibodies were not correlated as a single assay to venous thrombosis and only weakly to arterial thrombosis. And at that time, the antibody to glycoprotein-1 was not so long on the market, so there were not that many studies. But again, also the antibody to glycoprotein-1 ELISA was only weakly correlated to the clinical manifestations. So very important is that lupus anticoagulant is the strongest risk factor for every type of thrombosis. And after the study in 2003, many more studies have been done, and all the results obtained after this Medline search have confirmed these first conclusions. Lupus anticoagulant correlates best with the clinical manifestations. And in fact, single positivity for anticoagulant antibodies does not correlate with the clinical manifestations. There are now many studies that if you measure anticoagulant antibodies as a single test and all the S is negative, there's no correlation, at least with the assays as they are on the market today. So that is an important conclusion. There are some guidelines nowadays how to measure lupus anticoagulant. First, you have to be sure that your plasma that you use does not have any residual platelets, or at least not very much. So normally you have to spin down your plasma twice to get rid of your residual plasmas, and your plasma count should be less than 10,000 per microliter. Then it was proposed to do two different assays, two different coagulation assays, one based on two different principles, and the suggestion was to use an APTT-based assay and an assay based on the Russell Viper venom time. And if these are prolonged, you have to show that this prolongation is not due to clotting factor deficiency by mixing the plasma with normal pool plasma. So the combination normal pool plasma and patient plasma should still be prolonged. And if this is still prolonged, you should show that the inhibitor is dependent on phospholipid. And you should show that by adding extra phospholipid and showing that by adding extra phospholipid, you shortened the coagulation time. So that is very important. And these guidelines have been recently published by the SSC 2 years ago. What about beta-2-glycoprotein-1? Because everybody now knows that beta-2-glycoprotein-1 is probably the important protein in the syndrome. And the auto-antibodies against beta-2-glycoprotein-1 only correlates weakly with the clinical manifestations. How can we explain that? Now, there are many different explanations, but one of the most important explanations is that there are many different antibodies against beta-2-glycoprotein-1 directed against different domains of the protein. But there are now many studies by different groups all over the world who have now shown that specifically the antibodies that recognize domain 1 of beta-2-glycoprotein-1 are the important antibodies. And the antibodies directed against the other domains are probably of no relevance. So you have to focus on one single part of anti-beta-2-glycoprotein-1 antibodies, the antibodies directed against domain 1. And there are now assays coming on the market that are directed specifically to this specific part of beta-2-glycoprotein-1. There's one problem. The antibodies against domain 1 have a very high specificity. If you have the antibodies, you absolutely almost all the patients don't have thrombotic complications, but the sensitivity is low. There are many patients in the antiphospholipid syndrome who do not have these antibodies and still have thrombotic complications of pregnancy, morbidity, and we do not know exactly what it means. Does that mean that there are different antibodies that can cause thrombosis, and we have identified here one subpopulation that's important, or that there's something else going on? You do not know. But we have at least identified one population that is quite important for the clinical manifestations. As I said, the antiphospholipid syndrome is a disease that is defined in the laboratory. And patients diagnosed with the antiphospholipid syndrome are very often treated longer or more intense with antithrombotic medication. So the different assays used to detect the antiphospholipid syndrome should therefore be very reliable, because your treatment depends on the results of the laboratory. And how reliable are these assays? And there's a problem. I have an example here from the European Concerted Action on Thrombosis. They sent around they have an external quality assessment program, and in this program there's also the antiphospholipid antibodies. And here's the result of one specific round in 2006, and one sample was measured in more than 200 different laboratories, and that are university laboratories, so not the simple laboratories, but really good laboratories, high quality laboratories. And the result of this sample was that 16% of the laboratories considered this sample as positive, and almost 7% considered it as strongly positive, with everything in between. So it is absolutely unclear whether this sample is positive or negative. Depending on the laboratory where you go, you have here a result that is negative and positive. So the question was, and Piet Meijer, who organized it, was a clever man. He decided, well, I sent the same sample around next time, see what happens. So he sent the same sample 9 months later around, and he got again the results. And what you see was quite good, in fact. Although the results are, again, horrible, is it a positive sample or a negative sample? But the results are more or less the same. 60% was negative, now 20%. 7% was strong positive, now 5%. But more or less, the same results were obtained as the first time. Was it really true? Well, if you compare these two results, then you see that somebody who, in the first round, considered it as strongly positive, 11% considered as strongly positive, now considered the same sample as negative. Same laboratory, same sample, other day. And also, the laboratory who considered the first sample negative, now 30% of them consider it as positive. So it is absolutely a mess. Not only it's very difficult to measure properly whether the antibodies are there, if you look carefully, the same laboratory measures have completely different results with the same sample the next time, which is a problem. So is it possible to detect these autoantibodies? Well, I think a very important publication came from the NICWAS exercises, and they looked when these samples were well correctly interpreted or not. And here you see that if you send around a sample of a strong lupus anticoagulant, 95% of the laboratories can measure that. If you send a normal pool plasma, 95% of the laboratory can measure that. But if you send around a very weak lupus anticoagulant, so mark the area where there's the cutoff, then less than 50% can determine the proper sample. And it becomes more complicated if you send around a sample, for example, for a hemophilia A or B patient. They were prolonged and they considered that as lupus anticoagulant. So there's a big problem. But still, it's with the weak samples. So what to do? There is ample evidence now in the literature that when a patient is positive in all three assays, they have a much better correlation with thrombosis and pregnancy morbidity than it is positive in a single assay. Probably because then you measure the high titer antibodies. But I think an important complication is that you do not have a problem with single false positive results, because it is not very likely that you do it 3 times wrong, so you select more or less for the real positive patients. And recently he published an article, Victoria Pengo published an article in Blood, where he has studied the risk of recurrence, and he showed that the risk of recurrence is significantly higher in patients with thrombosis when they have all 3 assays positive, but then in patients who do not have the antibodies or are positive in only 1 or 2 tests. So clearly, if you have all 3 tests positive, then you have probably the proper patients. So I think that is an important message. All 3 assays positive, then you have really identified the patient risk, because you pass by a little bit the problems of detection. I think it's also important to realize that you have to have a kind of patient selection. The antiphospholipid syndrome is typically a disease that for the younger persons above the age of 50, the correlation of the antiphospholipid antibodies, the clinical manifestations disappear. We do not really know why, because there are probably so many other risk factors. But if you have a high probability, then you have a patient with an unprovoked deep venous thrombosis, a patient with arterial thrombosis at the age of lower than 50, if you have thrombosis or fetal loss in patients with already an autoimmune disease, and when you have thrombosis at unusual sites. There's a moderate probability if you have an accidentally found prolonged APDT and asymptomatic subjects, a provoked deep venous thrombosis in young patients, or recurrent spontaneous early pregnancy loss. And in elderly patients, the probability is extremely low. So it's clearly a disease for younger people. I will say a few words about treatment. There are much more reviews written about treatment than studies done, and most of these reviews have eminence-based opinions and not evidence-based opinions. And most of these studies have a problem because they have included patients that are positive in 1 test that's sufficient. So the conclusions of most of these studies is very difficult and are hardly any prospective studies. And there was recently, some time ago, there was a prospective study started in the United States, a very large study, and that was terminated because the number of recurrences was too low. In some of the reviews you see that they think there's a recurrence up to 60% every year if you have the antiphospholipid syndrome, And the larger study was more or less based on these presumptions and turned out not to be true. If you treat your patients well, the recurrence rate is very, very low. It's about 25% in 5 years. And then the large study was stopped because the number of recurrences were low. But there are 3 things to realize. There's the duration of the treatment, and the official recommendations is that you have to treat longer. And that is probably true. Everybody agrees on that because the risk is indeed higher. But the optimal duration of anticoagulant or venous thrombotic complication following the first event is uncertain because there are no good studies done. So you should treat longer, but how long depends on what you think yourself because it's not supported by studies. The intensity, the first publication suggests that all these patients need a very high intensity of INR. The Kamasta study published in New England Journal of Medicine. There have been a number of randomized studies afterwards, and all these studies show that high-intensity treatment is not necessary because there was no difference between the high-intensity treatment and the normal treatment of these patients. There are a number of people who suggest that you should prophylaxis. If you identified a patient with antiphospholipid antibodies who did not have had a clinical event, some of them advocate that you immediately start prophylaxis. I would say that there's no study showing that there's any benefit of prophylaxis, simply not studied. So in our laboratory, we do not do that because we do not know whether the antiphospholipid antibodies that were measured are really a risk factor. So we wait. But there are people who suggest do prophylaxis, but there is no study showing that it helps. Maybe we think real patients by only taking those patients that are positive in 3 tests, maybe we can do then a good study and showing that maybe it helps if you are positive in 3 tests. The second half of my talk, I want to talk a little bit about beta-2-glycoprotein 1. Beta-2-glycoprotein 1 is the protein that is thought to be the main protein in the antiphospholipid syndrome, the bad guy. And beta-2-glycoprotein 1 was first described in 1961 as a plasma protein, and already in 1968 the first person was identified with deficiency in this protein, and this person was completely healthy. Later on, 3 or 4 more persons has been described deficient in beta-2-glycoprotein 1, and these patients have no phenotype. Protein was not very popular to study, but when it was associated with the antiphospholipid syndrome in 1990, it became very popular to study it, but still we do not know a function. And in 2001, a knockout mice was described, and these knockout mice were completely healthy. And after this first publication about these mice, no other publications has appeared suggesting that these mice are really healthy. So what about beta-2-glycoprotein 1? We have solved the crystal structure, but there was one big problem when we solved the crystal structure. Because there are no circulating antibody beta-2-glycoprotein 1 complexes in patients with antiphospholipid syndrome. The antibodies are there, the protein's in the circulation, and there are no immune complexes. Also, the level of beta-2-glycoprotein 1 in patients with the antiphospholipid syndrome are similar than controls. There's no clearance of the beta-2-glycoprotein 1 due to the presence of these antibodies. And if you do a very simple study and you take beta-2-glycoprotein 1 and you coat it on a plate, the patient antibodies will recognize it. But if you do it vice versa and you take the antibodies and you coat them on the plate and you try to bind beta-2-glycoprotein 1 that is present in plasma, no binding will take place. So the epitope that is recognized by these antibodies is hidden, is cryptic, and is not recognized by the antibodies in the circulation. Only when beta-2-glycoprotein 1 binds to a surface, then the epitope is exposed and the antibodies can bind. And that was a problem, because we have identified the crystal structure. We know that the antibodies recognize domain 1, and we and also others have made all site-directed mutagenesis to identify the binding site of the antibodies in the protein. And it is there where it's here. Here the antibodies recognize beta-2-glycoprotein 1, and it is not hidden. It's exposed on the outside of the molecule. So how is it possible that the antibodies doesn't recognize this protein while the epitope is exposed on the surface? That was a long problem. And finally, we dissolved it by starting doing electron microscopy studies. And here you see what we see. If you take beta-2-glycoprotein 1 and you study it under the electron microscopy, you see circles. It's a circular protein. And when you incubate it with the antibody, you can see here the antibody, and here you see beta-2-glycoprotein 1. It's exactly like the crystal structure. Here you have beta-2-glycoprotein 1. Here you have an antibody recognizing domain 1. Here you have an antibody recognizing domain 1. Here's the beta-2-glycoprotein 1. It's an open structure while exactly as the crystal structure, because in plasma it's circular. So apparently binds to the surface, it opens up, it becomes from a circular structure to an open structure, and the antibodies can recognize a domain in epitope in domain 1 that is probably inside the molecule in the plasma conformation. And I think that is important, and you can think of what does that mean for the presence of the antibodies and the pathophysiology of this disease. There is a general consensus that the autoantibodies in general are the consequence of an infectious disease, and infections cause the development of these autoantibodies. This is for every autoimmune disease, and also for the antiphospholipid syndrome, and also for beta 2-glycoprotein 1. And there are two major theories how infections can induce autoantibodies. The major theory is molecular mimicry, that thinks that autoantibodies are formed due to the consequence or conformational similarity, the sequence of conformation similarities between the bacterial or viral peptides and amino acid sequence, in our case, in beta 2-glycoprotein 1. So there is a similarity between amino acids or the structure between the bacteria, virus, and beta 2-glycoprotein 1. But there's also another theory by Rose, who thought that infections are adjuvants. An adjuvant enhances also the immune response by unfolding the protein that you inject, resulting in exposure of antigenic epitopes that are normally shielded. That's the effect of an adjuvant. So is it molecular mimicry or is adjuvant? And when we had these results, we thought maybe it's the adjuvant effect, because you open up the molecule, let's see what happens. So what are the consequences for the conformational change within beta 2-glycoprotein 1 if you inject that into a mice? So we cloned mice beta 2-glycoprotein 1, and we injected that in mice and fragments thereof. And when you inject mouse beta 2-glycoprotein 1 in mouse without an adjuvant, you do not get antibodies. But if you add it together with carylipin to open it up, you have antibodies. And that was already known in literature, that if you inject carylipin into a mouse, we get antibodies against beta 2-glycoprotein 1. And here you can see exactly what happens. And these antibodies are directed against domain 1 of beta 2-glycoprotein 1, not against the other domain. So simply injecting open bed structure, you get the antibodies. You can also take the single domain and all the other domains, inject them into mice, and what you see is that you have, if you inject domain 1, you get antibodies. If you inject the other domains, you do not get the antibodies. So you inject a domain 1 of beta 2-glycoprotein 1 of mouse origin into a mouse without adjuvant, you have within a few weeks, you have the antibodies. So apparently it's very easy to make these antibodies. This exposure of the cryptic epitope is enough to induce this formation of these autoantibodies. The question is, can we then link that to infections? And I give an example for Streptococcus pyogenes because we know a little bit about this bacteria, and we have found in the past that there are 4 different proteins present on the surface of Streptococcus pyogenes that can bind to beta 2-glycoprotein 1. So we did a study again. Here you see beta 2-glycoprotein 1 isolated from plasma, all kinds of circles. Here you see M1 protein from Staphylococcus pyogenes, and here you see the complex. It binds as a circle to this protein. But if you take protein H, which on itself is also a long stretch molecule, if it interacts with beta 2-glycoprotein 1, you see that it opens up and that you have this open structure where it opens up, while if you take the other 2 proteins, it binds as a circle. So apparently, if you incubate these 4 different proteins with beta 2-glycoprotein 1, only with protein H, you see this conformational change. So the next step was simple. We injected the mice with the different proteins isolated from Streptococcus pyogenes. And if you inject a mice with protein H, they make antibodies against beta 2-glycoprotein 1. If you inject mice with M protein, you do not make the antibodies. And if you inject it with SLA or SLB, they do not make the antibodies. It's clear that if you inject with a bacterial protein, you get an antibodies against beta 2-glycoprotein 1, and you have maybe the syndrome. And if you look to which domain the antibodies are directed, they are directed against domain 1 and not against the other domains. So apparently all the mice we injected with protein H, they make antibodies against beta 2-glycoprotein 1 and against domain 1. And how important is that? Well, we did our first studies in the thrombosis model, and you can clearly see if you take a mice and you inject it with protein H, thrombus formation is much faster than if you inject a mice with protein M. So apparently you can now simply build up the antiphospholipid syndrome in the mice. It has at least thrombotic complications. We have not seen any effect on pregnancy complications up till now, but at least you have one part of the syndrome is now ready to study further because we can induce now a mouse model by simply injecting one simple protein from a bacteria into a mouse. And I think there will be more proteins to be found that do exactly the same, and I will give you an example of that. The next question is the function of beta-2-glycoprotein 1. It is present in high concentration in plasma, and in fact it is extremely conserved in mammals. Here you see a crystal structure of beta-2-glycoprotein 1, and we have made yellow all the amino acids that are conserved during the whole mammalian evolution. And you can see the greater part of the molecule is extremely conserved in mammals, and even in vertebrates there's a very high conservation. Combined with the very high plasma concentration, it is very unlikely that we have beta-2-glycoprotein 1 in our circulation without any goal. Although, if you do not have it, you're healthy. So, how to solve that problem? Well, we thought, if a deficiency in man and mice does not result in a clear phenotype, what happens with beta-2-glycoprotein 1 in different diseases? I give you an example, and we take patients with sepsis. Here you see the normal population, beta-2-glycoprotein 1 levels in normal population. You see there's a huge variation. Some people have very low levels, other people have very high levels, but the mean level is about 200 micrograms per ml, about 4 micromolar. But if you take patients with sepsis in our hospital, you saw that the mean level in these patients is about 1/3 of the level in patients in the normal population. And some of these patients we were able to get a sample during recovery, and you see that the level of beta-2-glycoprotein 1 increases when the patients recover. Apparently, there is a consumption of beta-2-glycoprotein 1 in an acute clinical episode. So what does that mean? So we first studied what happens with LPS if you add it to beta-2-glycoprotein 1. Again, here's the circular structure of beta-2-glycoprotein 1 in plasma, and here's beta-2-glycoprotein 1 if you incubate that with particles with LPS bound to it. You see, it opens up. If you do the same with albumin-coated beads, you do not see the opening up. Apparently, LPS opens up beta-2-glycoprotein 1 when it binds to LPS. And that is in fact not unexpected, because there are publications showing that when you inject the mice with LPS, they make anti-beta-2-glycoprotein 1 antibodies. Very old publications, but they exist. And nobody ever looked to it, but you can find them back. So what did we do? We had healthy volunteers, 32 healthy volunteers in Amsterdam, that were injected with low doses of LPS and see their reaction. And we got the samples from Amsterdam, and what you see is that immediately after injection, the first sample taken after half an hour, the level of beta-2-glycoprotein 1 in the circulation has decreased with 25%. And all the other proteins, for the antithrombin of LPS binding protein, do not see this immediate drop of beta-2-glycoprotein 1. So apparently, inject LPS, it binds LPS and it immediately disappears. But what was more important, we correlated the level of beta-2-glycoprotein 1 with the temperature rise these individuals suffer. And what you see is that if the volunteers with low level of beta-2-glycoprotein 1 have a temperature rise of about 3 to 4 degrees after injection of LPS, the maximum increase, but those persons who have a very high level of beta-2-glycoprotein 1 have only a relatively small increase of the temperature. Apparently, beta-2-glycoprotein 1 protects you from a rise of body temperature. And you can see that in different ways. You can also see that for TNF-alpha rise and the IL-6 rise in these patients correlates negatively with the level of beta-2-glycoprotein 1 they had when this study started. So apparently, beta-2-glycoprotein 1 can protect you from LPS infection. So apparently, beta-2-glycoprotein 1 is a protein that is involved in innate immunity. It is neutralization of LPS beta-2-glycoprotein 1. It's in fact a two-step. It binds and it is then uptake by the monocytes. So binding alone is not enough to prevent the effects. It should also be cleared from the circulation and it's taken up by the monocytes immediately via an LDL receptor system. So apparently, beta-2-glycoprotein 1 plays a role in innate immunity. And that's interesting. We tried to find the site within beta-2-glycoprotein 1 where it binds, and you can see we have tried different peptides from beta-2-glycoprotein 1, and we see this is the peptide which you can replace beta-2-glycoprotein 1 from its binding, and this peptide is located here in a molecule. So there's clearly one peptide that is involved in the binding of LPS. And we find that quite interesting, because if you go back in the evolution and you take all the mammalians, and from human to Amarillo, the antibody binding site, the phospholipid binding site, and the LPS binding site are completely conserved throughout the whole mammalian evolution. And in fact, they are, for a greater part, conserved in the vertebrates. So apparently it is a very important part of the molecule, which should be exactly the same. So I think that beta-2-glycoprotein 1 is a scavenger, and this has been drawn beautifully by Jacob Rand, that beta-2 in the circulation is circular. It can bind to phospholipids and then it's opened up, but it can also bind to LPS, opening up, and then this is not any longer, is taken up by the monocytes, not via the TYR4 receptor, but via uptake by the LRP receptor. So apparently it can get rid of LPS. And if you go further in your study and you look back in literature, you can see that beta-2-glycoprotein 1 is in fact a scavenger for potentially toxic substances that are present in your circulation. There are publications showing that beta-2-glycoprotein 1s are involved in the clearance of plastic cells. There are a number of nice publications showing that beta-2-glycoprotein 1 is involved in the clearance of microparticles. There's a publication showing that beta-2-glycoprotein 1 is involved in the binding and clearance of oxidized LDL. There are publications showing that beta-2-glycoprotein 1 is involved in the neutralization of nitric oxide and superoxide radicals, and even there's a publication from our own group that's showing that beta-2-glycoprotein 1 is also involved in the clearance of von Willebrand factor. So I think that beta-2-glycoprotein 1 is a scavenger of potentially toxic substances in our body. So that comes back to the last part, the pathophysiology. I want to say a few words on the pathophysiology. I've made here a slide that you cannot read, and that's good, because this is a list of the proposed mechanisms how beta-2-glycoprotein 1 induces thrombosis. And this is not a complete list. The slide was not bigger, so I had to stop. But this is a list of all kinds of mechanisms that are proposed how antiphospholipid antibodies can induce thrombotic complications. It's very difficult for me to say which one is the proper one. There are many different possibilities. In fact, some quite convincing experiments done with knockout mice showing that this should be the case, but there are knockout mice deficient in a number of these mechanisms and all show more or less that they are protected from thrombotic complications. So it's very difficult to make a real decision. But I think that there is a message. That's probably because beta-2-glycoprotein 1 is a scavenger. It can influence different mechanisms, I don't know. But whether beta-2-glycoprotein 1 is involved in activating endothelial cells, for example by upregulation of tissue factor, whether the antibodies are involved in plasma proteins, influencing fibrinolysis of protein C axis, whether they are involved in monocyte activation or involved in platelet activation, the fact is that the antibodies increase the prothrombotic state. They do not really cause thrombosis, they make a prothrombotic state. And you need something else to induce the thrombotic complications. There's a large study in which they prospectively followed patients that they stopped to see, because there were not enough recurrences, all the recurrences occurred in patients which had also other procoagulant conditions. So apparently you need more than one. And then when you have a hit, then you got thrombotic complications. And there are quite good evidence that complement activation is also involved. So what do we now know from the antiphospholipid syndrome? I think that the important message is that patients with all three assays positive has the highest risk profile. If you need all three assays, in our hands, all the patients who are positive for anticardiolipin and cardiolipin antibodies are also positive for anti-beta-2-glycoprotein 1 antibodies. So maybe you need two, but all the studies up to now have done with all three assay positives. So these patients are the real patients and the highest risk profile. And that a subset of the auto-antibodies against beta-2-glycoprotein 1 seems to be responsible for the observed clinical manifestations. At least it's one of the populations. It's clearly indicated it is an important subpopulation of antibodies. Whether it's the only one, I don't know. I think that beta-2-glycoprotein 1 acts as scavenger protein in our circulation and that it can have different conformations. This induction of conformation is a trigger for the development of autoantibodies. Thank you very much.